Hello, everybody. This is Dr. Anthony Cave, your Stanford and Harvard trained anesthesiologist and integrative medicine specialist. And I was rather heartbroken yesterday. I need to share two powerful comments that came in that came from really desperate people, well intentioned, but echoed a tremendous pain and suffering that's been a result of the medical pendulum that most patients simply are not aware of. And this pendulum is driven by so many nefarious factors. Yeah, often greed, misinformation, and patients suffer, and we need to talk about it today. So I titled this No Pain, No Gain because it is really painful for me to have to read these comments, and you're going to see why. Stevens07 says, I have read over 100 comments. Speaking as someone who had two lumbar fusions and is in pain daily. I hope you are reading these, doctor. I talk to people all the time about this topic. I believe doctors are doing more harm than good, making real patients feel like there is no hope anymore. Going to funerals of people who would rather take their lives than suffer or end up taking a street drug laced with fentanyl, using THC or drowning in alcohol to help with pain. Please take all the feedback and do something positive with it. Advocate for your listeners, as that is so desperately needed, says Stevens, and that's why we're here. And I'm going to share a story with you. This is in response to my recent video on why doctors are so stingy with pain medications. I gave a very powerful story in that video. I'm going to give you another powerful story from the other end of the spectrum today. A patient was not mine, was of a colleague's though. And this individual had come in to the chronic pain clinic with multiple motor vehicle accidents, severe back pain, multiple back surgeries. And unfortunately, one of them had been due to a DUI, which is abhorrible, but does not, and I really need to make this clear, does not excuse undertreating pain. That's not the perspective here. I'm just sharing with you how real the story was and how unfortunate it was. Multiple back surgeries, failed back surgery syndrome, living with chronic daily back pain. In 2016, when the CDC released guidelines, and thank goodness we're not there anymore, but after 2016 up until 2022, we were, this patient was treated not as a human being, but as an MME. Do you know what MME stands for? And how it's potentially dehumanizing to patients? How dehumanizing it is just to label someone as they're an 80, they're a 95, they're a 63. Morphine milligram equivalents. So there was for some time great difficulty in putting anybody over 90 morphine milligram equivalents per day because of fear of the political sword by doctors. And what happened to this patient? Exactly what you think. Left in chronic pain, and they were found in a bathtub, nearly completed suicide. Fortunately, they were safe, but not with an indelible trauma loss to so many of those around this individual. What happened here is exactly what Stevens brought up. Aro brought up another comment, and I need to read this because it gets exactly to this point. I've abbreviated these, by the way. They're quite long. Arobe says, I really hope people read this comment section in particular. Suicidal ideation and suicide has become a huge problem for true chronic pain sufferers. There are too many chronic pain patients in crisis right now due to the opioid crisis. The abusive actions of some have caused needless, horrendous suffering of too many. I have chronic pain that will be with me for the rest of my life unless there is a very miraculous medical breakthrough. We're going to talk about all these because these are spot on points. They continue. Is it really a wonder why a sharp decline in mental health and increased suicide and suicidal ideation has become so much more prevalent in these communities? I apologize for the lengthiness. This is a very touchy subject for me personally. Aerobe, it is for me as well, and for all the patients that I see who are suffering from either opioid use disorder or chronic pain, not getting the opioids, or I should say, the correct pain management that they deserve. It's not about risking too little or too much. It's about getting the right amount and striving every single visit to get the right amount. Now, there's 5 things we're going to talk about, and These are all very, very important. So thank you for all for raising awareness of this. And I want to make sure that your voice is heard and ultimately what you can do to advocate for yourselves. We're going to talk about one, the difference between the emotionally impaired addict and the psychologically well pain sufferer. Unfortunately, these two get lumped together because of political ineptitude. Number two is, what are the physical risks of undertreating pain? You think it's just feeling bad all day? Because no, it's far more than that. And you need to know the physical things that can arise in your body from undertreated pain. Undertreated pain. I want to be clear about that. And then number three, why is chronic pain different today than it was 15 years ago, 25 years ago? Because our definitions are simply outdated and our practice guidelines are often way too old. And this contributes to more suffering today. You need to know that difference so you can advocate for yourself. You need to know about the medical pendulum, like literally, this is like a stupid prop, right? But it's like literally a pendulum. Once again, because of political pressures and financial gains, we are constantly either in one end of the pendulum swing or the other end of its arc. And who suffers when we go back and forth with extremes? It's patients who suffer and the doctors and nurses, et cetera. But it's the patients that we're here to talk about. They suffer. Why? And lastly, how do you advocate for yourself given all this? I'm going to share some very tangible tips that I hope that you can take to heart. And I do want to acknowledge all the people in the chat right now. Irene, good to see you. Alexis, Chris M, Linda, as always, Pixie, Sandra, etc. Thank you all for your support. And I hope that everyone here is appreciating that I'm here on a weekend because this subject really hit me hard when I was reviewing comments yesterday. If you could hit that like button and more importantly, share what you've learned with others to help others who are struggling with chronic pain to better advocate for themselves with their primary care docs, with their pain specialists, with surgeons, whoever it is in their life, so that they get the care that they deserve. And if you support me trying to advocate for you, your support by subscribing, whatever, always helps me do this more often for you. I'm not going to put ads on here for you. I'm not going to do product placement as long as I can manage. Thank you for your support and for bringing awareness of this topic for everyone. So this is so important. The emotionally impaired addict versus the psychologically well chronic pain sufferer. Heidi, thank you for that. I appreciate that. Karen Brown Barrio says, I'm a pain sufferer. How many people here in this chat are already acknowledging that what they're suffering with? Thank you for your vulnerability and sharing and recognizing that, you know, I live in San Francisco and I practice throughout the San Francisco Bay Area where the opioid crisis is absolutely a huge problem. And how unfortunate is it that politically two groups of very, I can't emphasize this enough, very distinct people have been lumped together. The people in the Tenderloin, and you've seen videos where I've shown you how deplorable these conditions are, once again, for political ineptitude, has led to immense suffering of the homeless, disadvantaged, etc. population. And how, for political reasons, doctors need to treat patients who are psychologically well, yet suffering from chronic pain. They need to lump them together effectively. Not exactly, but effectively, because we can't, up until quite recently, I should say, in 2022, there were some revised guidelines that are still largely laughable for reasons I'll explain from the CDC. But up until 2022, we ran the risk of, once again, political sword if we put anyone above 90 morphine milligram equivalents per day. Why? Because of the very real risk of the opioid epidemic. But I know, and you know, that so many chronic pain sufferers are not out there in the Tenderloin illegally obtaining fentanyl-laced drugs, etc. So this difference we have to acknowledge and we need to all recognize, and I'm acknowledging for you and hopefully any doctors anywhere around the world or residents or medical students, please, in your brain, always acknowledge with your patient how distinct these two groups are and say that to your patients so that they know that they are heard. And, you know, if you have doubts about it, the patient and the doctor have to both acknowledge that, you know, I have concerns because the opioid contract has been breached 3 times in the last year or has been breached once in the last month. If that conversation, if that communication is not there, these two groups risk being conflated. It's only with clear communication that we can make sure both stakeholders are absolutely on the same page that these are different populations. I appreciate that's common sense for most of us. It does not translate in the busy 15-minute tops visit you get with your doctor in the United States, at least. If we don't set that boundary, the remainder 14 and a half minutes might be a complete waste of time and might lead to more suffering. Number two, the dangers of undertreating pain that you need to know about so you can specifically share with your doctor if you are feeling these, because this adds urgency to your chronic pain being treated. With opioids, in some cases is appropriate, in many cases may not be. But doesn't matter if it's opioids or not, it has to help you relieve your suffering. Okay? It has to help. The end goal is not whether it's opioids or not. The end goal is you not suffering because, one, the risk of major depressive disorder, which can lead to heart disease, which can lead to suicide, which can lead to an increased risk of dementia. These are very real risks. And we don't have medications that can undo these. So if you are on the verge, if you are experiencing symptoms of depression that are coinciding with your chronic pain, you need to tell your doctor this. Because giving Zoloft, giving Prozac, Wellbutrin, this is not going to treat the underlying reason of depression. And how many patients have I seen who are on all these psychiatric medications, yet they're still in chronic pain? And I'm just thinking to myself, holy guacamole, how are we not addressing the root cause of the depression? We're just putting this is a human being we're dealing with, guys. This is not some like random barcode that's coming up in front of us. This is a human being. This You can't just throw medications on someone and hope it's a band-aid until the next time they come to your office. Surely no doctor in their right mind would ever want that for a patient, yet forces are at play that inhibit our ability to individualize care, inhibit our ability to address the root causes of suffering, and instead just allow for this suffering to continue and continue and continue. Totally inappropriate. But if we don't address the root cause, which is often pain, whether physical or emotional, what good is all of the other band-aid solutions going to be for when they're used for extended periods of time, other than possibly introducing dangerous side effects? Linda, thank you so much for that. Thank you there. I really appreciate that. That's very kind of you, especially after yesterday. Thank you. And Miriam Hope says, human being. Yes, it is human being. We are not barcodes. We're not products of human doing. Please. I deserve as much respect and dignity as my patient does, right? And not addressing the root cause prevents human beings from being treated as such. Now, another result of untreated pain can be generalized anxiety disorder, or it can be situational anxiety. And what happens when we have anxiety that interplays? Remember, in the words of Dr. Judd Brewer here, inwardly focused perseveration and rumination of the past is depression. Of the future, we call anxiety. These two have a fertile growing, soil here inside the body of somebody who's suffering from chronic pain. Once you add generalized anxiety to the picture, now you have somebody who might be prescribed benzodiazepines. They may have trouble sleeping because of this inwardly focused perseveration and rumination that contributes to insomnia. They may be given sleep aids that may or may not be addictive. Benzodiazepines that have tremendously dangerous side effects when mixed with the wrong medications. Now, there's a time and a place for them. Ideally, not as a destination therapy, which you should watch my previous video where we talk about the difference between bridge and destination therapies. Now, once again, chronic pain, I see patients on benzodiazepines, on other anxiolytics, and on sleep aids all the time. How many Remrons or Trazodones am I seeing in patients? A little bit of Xanax for sleep when they're in excruciating hip pain or back pain or knee pain or whatever pain. Or it could be emotional pain, by the way. They are very, very closely related because of the mind-body connection. What are we doing? Are we just trying to make benzodiazepine addicts who risk overdosing if they get one drug laced with fentanyl? That's just like one break point away from overdose, right? It's a one-way street. Totally unacceptable. Another real danger of undertreating pain is in children. We never talk about this because all those comments in that video, which you should read, at least a handful of, I didn't see any from children. Children are having more surgery today than ever before in human history because of miraculous advances in our ability to perform surgery in children, whether it be for congenital heart disease, for neurovascular disease, for any number of conditions that kids were just left to die in the past. So we have incredible, I mean, really miraculous treatments available. But now we have kids coming out on the other side of these successful surgeries with chronic pain or undertreated pain. It's bad enough when an adult has to live with chronic pain. What about the child who has undertreated chronic pain? Can you imagine what this does to the developing brain of a child? What kind of adverse childhood experiences is this child going to have for the rest of their life? Marianne Hope is right. Children are in pain also, 100%. Sophie says, I'm on gabapentin, clonazepam, zopiclone. Actually, I don't know the other name for that. Zopiclone and duloxetine. A disaster and still in pain. Sophie, my heart goes out to you. Thank you for your vulnerability and sharing that. And it just shows that we're not addressing the root causes. I'm so sorry that you're suffering with that. But we got to look at kids because kids who are not being treated for their pain are at risk of having any number of mental and physical health conditions. So you have a great life-saving surgery, you treated the congenital heart disease, and now they're going to live a life of misery and suffering. And this is unacceptable. Please, please, we cannot undertreat children any more than we can adults for their pain. I wish this was obvious, but clearly from the comments, it's not. How about heart attack risks? If you have surgery, you're going to have pain after, right? It's highly variable and dependent on your preoperative mindset, which is why I always say mental health matters before surgery. And Bonnie Hayner, thank you so much for that kind. Thank you. That's very nice of you, and I really appreciate that kind comment. Thank you. Our mindset before surgery impacts whether that pain is likely to turn into chronic pain. So whether it's just going to be pain after surgery that maybe will be like long-term pain for months or years after. Well, the mindset affects that. And your preparedness, your expectations, have you talked to the surgeon, et cetera. So many factors go into your mindset, but we never talk about these before surgery. At least I haven't seen very many patients psychologically optimized for surgery. And if you go from acute pain to chronic pain after surgery, what's that going to do for the success of your surgery? This is a human being we're talking about, not just somebody who's going to be a meat bag on an operating room table and discharged home to live in misery. That's not appropriate. Yet, unfortunately, this kind of is the ethos in some operating rooms. I'm not saying that doctors are bad or nurses are bad, but I'm saying the system does not allow for this personalized, compassionate care in these stressful situations. Alexis, thank you as well. Maybe I can, Alexis asks, can I do a live talking about how people of color are treated differently when presenting to the ER for severe pain? Alexis, that is a deep question. We need to do a whole live on that. That's a tough one. Yes, I appreciate your contribution there. And yes, I will make it a point. I'm going to write that down right now because that is a very, very touchy subject as well. That's you're hitting all the right points, Alexis. Now, I did mention heart attacks as well in pain. If you have a heart condition and you have surgery and your pain is so undertreated that your heart rate goes up, your blood pressures narrow, your blood vessels, constrict or narrow. It's not unheard of to have patients actually have heart attacks from the severe pain after surgery. It's not common, but the effects on the cardiovascular system from living in acute pain, at least, or having episodic acute pain, can have disastrous consequences for your heart and your brain, etc. This is not the same as chronic pain necessarily, but there's a lot of overlap, and it shows the physical problems with undertreating pain. Okay, let's move on to why chronic pain needs an updated definition. Chronic pain typically was broken into cancer pain and non-cancer pain. This is really important. Cancer pain and non-cancer pain, where typically cancer pain was treated with opioids. Why? For the reasons that you suspect. Because when you're terminally ill with cancer, you are probably less likely to suffer from the risk of addiction, etc., as you are to suffer from dying in severe pain. What is the problem today in the 21st century? And with this definition is that, well, gee, I don't know, we have survivors of cancer more than ever before. We have medical technologies, like I mentioned, that are allowing people to live who would have otherwise died long ago. But they are living with chronic pain that is not amenable to just Tylenol and ibuprofen. Those are powerful. Don't take this, don't take it the wrong way. There are powerful ways of addressing pain without opioids, but the amount of tissue damage, the amount of psychological trauma, etc., all contribute to the intensity of pain. And that pain has to be recognized as different today than it was 30 years ago when we didn't have these life saving therapies. How about people that are living with chronic conditions who would have died 20 years ago? HIV neuropathy is just one example. Well, you can't use cancer and non cancer as the only binary fork in the road, if you will, because people today now are living in ways that they couldn't live 20 years ago. Eleanor Cantillo, thank you. Um, I appreciate the kind comment, Eleanor, and I sincerely hope that you do find a doctor who can help you heal from your chronic pain and find the right middle of the road, not too little, not too much, but the correct amount for you, degree of therapy for your chronic pain. Um, so, sorry, I just had to review a couple basic notes. This is, largely this is all live and unscripted for you, but I have a couple notes that I needed to make sure I get across. I was just peeking at that. Sorry for the pause. So, this has led to a pendulum effect, and you need to understand the pendulum effect because you and I and everyone suffers greatly from this politically motivated pendulum effect and economically motivated. There are several breakthroughs throughout the course of medical history that have pushed prescribing habits and other sorts of medical interventions in ways that go to one extreme and then a couple years later to the other extreme. Opioids are the most common example today because, as you know, Purdue Pharmaceutical, et cetera, led to various conditions being heavily treated with opioids. And then, because of opioid related deaths, the pendulum swung in the other direction. And now we have the opposite problem where psychologically well people are not receiving the appropriate pain control that they may need. This is not the only example, though. How about SSRIs and stimulants? This is a huge one, much bigger scale in some ways. When we look at depression, after the advent of SSRIs, after tricyclic antidepressants, what we call TCAs, huge push for SSRIs, Prozac being one of the first. How many people are being treated with antidepressants as destination therapies, meaning they're going to die taking this? And what kinds of side effects are we going to see in them as they get older? I mean, gee, we talked about them before, but sleep related disturbances, REM sleep disruption, dry throat, weight gain, nausea, constipation. I mean, the list is very, very large for these. There's a time and a place, absolutely a time and a place, especially as a bridge therapy. But we're going to eventually see a back or the pendulum going in another direction. Right now, we're seeing kind of psychedelics taking up the slack. And this is also going to go in a very extreme direction as well for various political and economic reasons. And we're going to see side effects from that push the pendulum in another direction in a couple of years. Another really big one is, I mean, we're living in it right now, Ozempic and GLP-1 agonists like Mounjaro. Right now, everyone's like, oh, this weight loss drug is a miracle. Well, we're going to overprescribe this thing to no end, as I'm sure we're all aware, right? What's going to happen in a couple of years when the first set of side effects come out? There's going to be a giant swing in the other direction. These swings are unfortunately the result of an unstable system. Like anywhere in the known universe, when you have large swings, that is a symptom of an unstable system that cannot regulate itself. This isn't like me saying this is just the law of the universe. These habits have also contributed to genetic testing being overtreated. When we made discoveries about basic gene related diseases, everyone went under this path of your genes determine everything. Completely disempowering, not medically accurate. But boy, did it make money when we could sell genetic testing for people. I'm not saying genetic testing is bad. There is a time and a place for BRCA1 testing, for certain 23andMe, Hey, Nikki Latimer, thank you for that. That's really kind of you. Thank you, Nikki. Very, very much appreciated. Genetic testing, how disempowering is it? And how much is this pendulum swung in the other direction? It's like everything is in your genes, this fatalistic view, deterministic, that you don't have any say in your health because you're a slave to your genes. How disempowering is this? Well, eventually we're going to see a swing in the other direction where it's going to be like, oh, everything is all in you can control everything with your brain. You don't need anything else. We're just going to instead sell you wellness products because you can control everything in your body by just, wearing that fancy Apple Watch or that other gadget. I mean, these are all economically motivated, right? But you're going to see that there's going to be swings in not only prescribing practices, but also economically what's targeted directly to patients. So recognizing that opioids are particularly deleterious. This is not only in opioids, you'll see them everywhere in medicine. And it's simply a symptom of an unstable system. And yes, the United States healthcare system is very much unstable. So let's end with perhaps the most important part of all. How do you advocate for yourself in the doctor's office? Once again, if you're learning something here, please share this with other people because these are some practical, tangible tips that I want you to have so you can take control over your life and over your health because you probably have more control than you've ever been told. And you certainly have an ability to advocate more than you are probably aware. Sophie Mansell, thank you so much for that. Thank you there. And you asked a great question. Do you think you could do a live on autoimmune disorders like Behçet's, fibro, etc., and the effects they have on the mind and body? Well, I will write that down, Sophie. Yes, there's a lot to be said about fibro. Behçet's is quite rare. I've seen one patient in the last 15 years with Behçet's, but fibromyalgia is much, much more common. I'm not an expert in fibromyalgia, but I see a heck of a lot of it. And there's a lot to talk about. I will make a note about that, and we will talk about that on an upcoming live. Thank you for raising awareness about that as well. So, how do you advocate? First is that you need to know that the WHO, forget controversies around COVID, whatever, they have a ladder. And Carl Jacobson, thank you as well for that thank you. I appreciate it. The WHO has a ladder for pain treatment. Yes, there's chronic non-cancer pain and chronic cancer pain, but regardless, most of us are going to fall on the chronic non-cancer pain. And you have to know where you are on this ladder so you can advocate with your doctor. As you can imagine, the ladder of treatment begins with the most benign and mild forms of treatment, acetaminophen or paracetamol if you're overseas outside the United States, also called Tylenol, non-steroidal anti-inflammatories, maybe gabapentin, et cetera, or COX-2 inhibitors. Then you have more invasive interventions. In some places, we might be doing nerve blocks, we might be doing nerve ablations, we might be doing low doses of milder opioids like hydrocodone, called Vicodin in the United States. And then you can go up to things like pumps, pain pumps, et cetera. And then at the highest point, you're going to have stronger opioids. So this is a ladder. You can Google this. It's free for everyone to see. It's published by the WHO. If you're still suffering with pain, ask your doctor, Doc, where am I on the WHO ladder? Where am I on the ladder? Because I'm not getting the pain relief that I need. That opens up a discussion, an informed discussion on how you can be an advocate for getting the treatment that you deserve. Where are you on the ladder? Recognize that a lot of what we call adjuvant, but adjuvant makes them sound not as helpful. These are powerful. Behavioral or mental health treatments are so important for addressing chronic pain. And if your ladder is not having every possible bit of help along the way provided to you, you have to demand authorization from your insurance companies and ask your doctor to do it. We don't like doing it, but hey, we have a duty. We need to do that. Then your insurance company had better pay for it. Unfortunately, many of them try to cop their way out of doing this. And you need to file a grievance with your insurance company if they are not providing you with the adjunctive tools to treat your pain. It's not a one-trick pony. Typically, high-dose opioids in and of themselves aren't going to help address your pain as best as it can be addressed. They might help with one big part of it, but you're still going to be suffering in other ways. We can't just be a one-trick pony and just give out oxycodone, just give out um, continuous oxycodone, OxyContin. We have to address you as a human being, the totality of who you are. And you have to demand the insurance company, file the grievance time and time again. You have to call your representatives. I do this all the time. They're sick and tired of me, but I don't stop because they need to know how much their policies of restricting access to life saving treatments, psychological or mental health, or life saving pain treatments. Because, like I said, if you develop major depression, anxiety, if you commit suicide, if you have cardiovascular disease resulting from any of these that stem from your chronic pain, that's life threatening. And we can't just put band aids when people are suffering mentally and physically from this. And your representatives need to advocate to make those funds available for you. So keep calling them, don't stop, and have all of your friends call them. Because if they don't hear it from us, they're going to be, unfortunately, in the hands of the economic powers at B. You know who they are. I'm not saying they're wholly bad. They're very appropriate and they provide life saving medications, but you got to advocate for yourself. And lastly, recognize that the CDC probably wants to be, well, they want to be helpful, but they have written in their latest set of guidelines, 2022, that chronic pain management must be individualized to you, the patient. Fantastic sounding on paper, but unless money goes towards allowing doctors to actually deliver individualized care, give you more than 15 minutes, give you more than 5 minutes, give you more than just enough time to get a refill for your medications, there's no hope. It's mission impossible that you're going to get individualized, personalized care. That makes it lip service. I'm not saying it's impossible, but money has to be put aside for you to be able to spend more than 2 minutes with your doctor. So you can get individualized care that might involve opioids, it might involve nerve blocks or nerve ablations. It can involve any number of modalities. We're not one trick ponies. You deserve more than just oxycodone. You deserve, if it's oxy, and everything else to get you the pain relief that you deserve. Um, with that said, thank you so much for everyone's support. Let's answer a couple of your questions before we sign off for the weekend. As always, your support helps me do this more often, and I really appreciate all your support. And we will talk about people of color and how they're treated in the emergency room. We'll talk about fibromyalgia. It's always a tough topic because of so many controversies around how it's defined and ambiguities in treatment for it, but it's still very important to discuss. And yeah, let's answer your questions here today as well. Misty Hammond, good to see you. Having the FDA reduce the nationwide supply is making the individualized plan lip service as well. Yes, Misty, we constantly have shortages of so many medications, including opioids, including ketamine, including lidocaine. You wouldn't believe how ridiculous and tenuous our medical pharmaceutical supply is in the United States, unfortunately. Irene says, it seems at times insurance tells you what you can take. Must keep calling and get questions addressed, even if you're getting gaslit. Yes, Irene, and that's why we need to file grievance after grievance after grievance about how egregious some of these practices are. I empathize with you 100%. For all those people that left all those comments in that video, my heart goes out to you. And one of the best things we can do is collectively advocate against all the legislators that are allowing these practices to continue. I'm not saying they're bad people, but if they're not aware of the severity of the problem, how can they advocate for us at the higher level? Linda, thank you for advocating at that level. I appreciate it. MEC, you're very welcome. MRH Diane Num. I just want to be basically functional, taking the least amount of meds, but then I'm automatically called addicted, but I'm not. Because if I'm having a good day, I don't take any more meds than I need to. MRH, Diane, you need to advocate for yourself in the doctor's office. If you have a new doctor, make it clear. You acknowledge that there's two camps. Once again, emotionally distressed addict, psychologically well, pain suffering. Make sure your doctor understands. Put it out there at the very beginning so it's clear that you are so engaged in advocating for yourself so there can be no ambiguity, hopefully, in the pain management plan that you get. Uh, Elliot Polak, I don't think I've seen you on here before. Good to see you. Why does CDC recommend IR opioids first before LA when LA are usually only dispensed in abuse deterrent forms? Okay, very great question. Uh, this is actually a very good question. The concern, um, abuse potential can be higher in immediate release, the IR, versus long acting LA. I personally think it's a little bit controversial. You're right, there are abuse deterrent forms um, that can make IR easier to adulterate. I can't say I fully appreciate why this guidance is so limited. Um, I don't have a good answer for you other than they are trying to always do risk mitigation, not only of the deterrent, like and just to, I'll explain to everyone right now what I mean by deterrence, but they're trying to um, give the biggest sledgehammer approach to minimizing individuals developing addiction and minimize the risk of diversion of those drugs to others. So what he's specifically asking, and like I said, I wish I had a better answer for who's making these decisions. They're not always clear to me, but many medications have deterrence in there. So you guys have heard of Suboxone. It's buprenorphine plus naloxone. The buprenorphine, if you could isolate that, could make somebody experience euphoria. Naloxone in there blocks the effect of that happening. So that if you adulterate the strip, you can't necessarily separate them enough to get the pure euphoria without getting the naloxone in there to block the euphoria. They're all deterrent measures, and there's many of these. There's various practices called parachuting. You can look that up online, where you try to put it in for one pass to let the stomach acid get rid of the deterrent, pull it back out. Now you have a more pure form that can be used for a more euphoric effect. And I only mention this not because I'm saying people should do it, obviously not, but it shows how the addicted brain will go to any lengths to obtain that substance that it is now dependent on and addicted to and suffering withdrawal from. So you can look up all these different, I mean, they're very sad, very, very sad, but people get chemistries literally in uh, basement chemistry to be able to separate these deterrents. So it's a very sledgehammer approach. Very good question, Elliot. Uh, very good. Karen Smith says music, opioids, if food may help your nausea, vomiting. Interesting, Karen. I wasn't aware of music therapy being used in conjunction. Let's do two more questions before we sign off. Lulu Love. I hear many pain patients going to the streets because doctor won't prescribe pain meds anymore. That's not good. No, it's not. And that's what the last video had an unbelievable number of comments describing, which is, of course, not anyone's intention and shows the effects of an unstable system that allows that pendulum to influence prescribing practices so heavily. Uh, and the last question, why are so many of us denied disability? I don't know the answer to that. The light wins. First time seeing you on here. Good to see you. As a chronic pain person, I have experienced much evil from the side of medicine. Hard to know who to trust. I have failed cervical fusion at 38, multiple surgeries. I'm not sure I need it. The light wins. I'm so sorry to hear that you had that experience. Failed back surgery or anywhere surgery in your spine is not as rare as we think. And when this leads to medical PTSD and suspicion and circumspection of any medical advice for medical professionals, demonstrates another failure of connection, of that physician patient connection that's so fundamental to medicine. So, while I'm so sorry that you've experienced that, I hope that you feel empowered to advocate for yourself and to find a doctor who will take the time to speak with you hopefully in an insurance company that will allow for that time so that you can build that trust again. Because if you inherently don't trust the doctor, you're not going to be able to heal the way that you would like, independent of what medications you get from that doctor. Linda, thank you so much for sharing your story here, and of course for your contribution. Everyone here, I appreciate your support. Please share what you've learned with others, so you can help them advocate for themselves. And remember that you have more power over your health than you've ever been told. Until next time,